Hello everyone, welcome back to DC Conversations. Today we are in conversation with Dr. VVS Chandrasekharam, who is a senior pediatric surgeon at Ankura Hospital, Banjara Hills, Hyderabad. Doctor, hello, welcome to our show. So we've been, you see a lot of cases on a day-to-day basis, and you must have seen that, abnormalities and, birth defects are on the rise. So what kind of cases are you seeing in the recent days?
Birth defects are, I think they have been common. It's not that they are common now and not before. But yes, some of them are actually increasing. That is for sure. Yeah. So the common birth defects, see, from head to toe, anything can go wrong. When the baby is developing from one single cell, I think that's the greatest marvel. From one single cell, the entire human being develops. Yeah. And so when the cell divides and it becomes various subtypes of cells going into various formation of various tissues, it's a marvel. It is surprising that it doesn't go wrong most of the times. If anybody else were to do such a complex process, then we probably would go wrong more times than what actually happens. Yeah. But having said that, yes, birth defects are relatively common. The common birth defects that we know about and it is discussed in the public forums are the heart defects, congenital heart defects. They are reasonably common. Then defects in the brain, the spinal cord, what we thought we will talk about a little bit today, the spina bifida. Then of course, as a children's surgeon, we typically deal with birth defects of the abdominal cavity, that is the liver, the spleen, pancreas, the stomach, the intestines, and the urological system. So we deal a lot with pediatric urology. In fact, my practice is 75% urology in kids. So we deal with a lot of defects of the kidneys, the urinary bladder, and the genital system, what we call as urogenital system. So generally the genital system is combined with the urological system. So, and then we of course also deal with defects in the chest, other than the heart. So, for example, in the chest, commonly we deal with what we call as esophageal atresia. Esophageal atresia is the foot pipe is not completely formed. There is a gap in the foot pipe. There is a break in the formation of the foot pipe. And majority of the times, the lower part is communicating with the windpipe. Okay. This is called esophageal atresia and tracheoesophageal fistula. That is one of the prototypes of the congenital anomalies which a pediatric surgeon typically deals with. Then there is another thing called as a diaphragmatic hernia. So diaphragm is the muscle which separates the abdomen from the chest. So see, the pressure in the chest is negative usually. We breathe, isn't it? Yeah. So when there's negative pressure, if there is nothing separating, the intestines can be sucked into the chest. That normally doesn't happen. Why? Because there is a diaphragm, there is a muscle there. Yeah. And there can be a defect in this muscle, because of which the intestines, the spleen, sometimes the kidney and the liver can all pass into the chest. Okay. So when the diaphragm is being formed in the fetus, in the unborn child, the formation is defective and a part of it remains either unformed or becomes weak. The result is the same. Everything goes into the chest through that gap. So in these babies, it is now being diagnosed regularly before birth on the ultrasounds. Ultrasound scan can usually pick it up. In majority, again, it may not pick up 100%, 90% it can pick up. So these children, when they are born, because of the intestines going into the chest, the intestines compress the heart and the lungs. Common on the left side. So the left lung and the heart are compressed. Lung is like sponge. You can just compress it. It's not a solid structure. It's just air bubbles, air. So when that happens, the development of the lung is affected, heart is also affected to some extent. So these children require very extensive ICU management after birth and then followed by surgery, which can actually cure many of them. So this is one which we see.
Yeah.
Then coming to the intestines, all kinds of abnormalities of the intestines are possible. There's nothing that is not possible. One of the common things that we see is absent anal opening. Babies are born with an absent anal opening. This is called anorectal malformation. In girls, the anal opening is many times located close to the vagina instead of the normal place. So that is common in girls, whereas in boys, a completely absent anal opening. You don't see anything. The bottom is completely closed by skin.
Okay.
So the intestine doesn't come down and make contact with the skin there. So it stops somewhere, and many times it communicates with the urinary. And the other thing is many of these congenital problems of the rectum, anus and all, they also have urological problems associated. So they communicate with the urinary tract. So we do a staged operation usually where 2 or 3 stages. We first divert the motion stool of the newborn baby because the baby can't pass stool.
Yeah.
Within 2 days the abdomen will distend and ready to burst. So we do a small hole in the large intestine to bring the stool out. When the baby is about 6 to 8 kilos, then we bring the intestine down to the anus. We create a new anus. So all these can, again, the good news is majority of these congenital problems are correctable. That's the good news. Of course, they require a certain degree of expertise both in the newborn babies management as well as expertise with the surgical management of these babies. That is why a subspecialty called pediatric surgery actually developed. So as I said, we can see blocks in the intestine. One of the common things we see is the absent anus. Coming to the liver, we can see jaundice in small babies because the bile ducts are not formed. So we reconstruct, we take the piece of intestine attached to the liver. So the bile drains directly into the intestine because there is no duct in them. That is another, it's called biliary atresia.
But invariably, every kid newborn would be, kept in an incubator or something saying that, the baby has jaundice. So how different is that?
Yes. So it's a very nice question. See, jaundice is extremely common. More than 90% of newborn babies have jaundice.
Yeah.
So if the baby has persistent jaundice beyond 15 days, that is when we start suspecting this kind of a problem. There are some special tests to confirm it, of course. Again, this is not the commonest cause of jaundice. Because I am saying this, not every jaundiced baby's mother needs to be worried.
Yeah.
But it is an important cause which we deal with. The other things which I said I deal with, which there is very little knowledge in the general public, is the urological anomalies, urogenital anomalies. Kidneys, the urinary system, the bladder, the penis, the testis in the male. Again, majority of the genital and the urological anomalies are more common in boys than girls. So I think God is sympathetic to women. At least the urological anomalies, majority of them are more common in boys. Of course, genital anomalies, obviously, the male genitalia are much more affected than the female genitalia by anomalies. And believe me, the genital anomalies I'm talking about are the commonest congenital anomalies of all the anomalies. Unfortunately, many people have not even heard about it. We all know there is a hole in the heart, congenital heart problem, somebody is sponsoring their surgery. We know all these things, some charity surgery. But do you believe if I say that the extent of the genital anomalies in boys, it actually exceeds the so-called heart and other anomalies.
Okay.
So we have many boys being born with one or both the testicles absent from the scrotum. So they are either high up, either in the groin or in the abdomen sometimes. So we wait for 6 months. If it doesn't come down, then they need surgery to bring them down and fix into the scrotum, because they're going to affect the fertility and all other functions later. And a testis which is high up has a much higher chance of developing cancer than a normal testis. This is a common anomaly, very common, undescended testis we call it. The second is what we call as hypospadias. Hypospadias is a genital anomaly of the male sex organ, that's the penis. So the penis is malformed. I call it the manufacturing defect of the penis. It's malformed. A normal penis should be straight and urine should come from the tip, whereas in hypospadias, urine comes from below. Below on the undersurface, the hole of urinary hole is located on the undersurface of the penis. It can be located within a centimeter, or it can be located sometimes close to the anal opening. The severity varies, mild, moderate and severe cases. And the penis is abnormally bent downwards. You know, you look at the penis, you know it's abnormal. And this is a very common anomaly. Why I'm talking about this is, there is evidence from the West at least. We don't have exact records in India as to how many kids are born, or how many kids, out of 1,000 kids, how many were born with these problems 50 years ago. And now out of 1,000, how many are born? We don't have those records. But in the West, there are records. And from the Western records, it is now proven that these genital anomalies, the two genital anomalies I have talked about in males, they are actually increasing.
Okay.
This is alarming. And a lot of studies are actually pointing towards non-genetic mechanisms.
So it's environmental factors?
Yes,
Okay.
it's environmental. I mean, lot of things are being discussed and studied as we speak, but nothing has come out to blame any one thing. But the common assumption, or the most popular assumption, is that somehow the water table and the foot, the table, the soil is getting contaminated with industrial wastes and chemicals. And these chemicals have a mild female hormone effect. The water we drink, the food we eat, it comes from the soil, obviously.
Yeah.
So they all have a minor female hormone effect. Now, when an adult takes that food or drinks that water, it may not show, because we have very strong hormones already inside, according to our sex.
Yeah.
So these small quantities, they don't show any effect on an adult. But in a developing fetus,
Yeah.
which is very, very, very delicate. So these are supposed to actually go and block the male genital formation, or completion of that formation, rather. Let me tell you this way. You know what I'm saying?
Yeah.
So this is one of the things. So I think we all need to be careful.
But is there no way you could actually detect this at the pregnancy stage?
Very interesting question. Yes, we can detect. In India, the problem is we cannot reveal. Suppose I say, I'm a radiologist. I'm doing the ultrasound scan for a pregnant mother. And I do the ultrasound and say, oh, this baby has undescended testis, or the testis is not in the scrotum. Normally also, for even normal babies, up to 8th month, the testis don't come in the scrotum. After 8th month only they come. But suppose after the 8th month I do an ultrasound and tell the parents. First of all, it's not going to be of any benefit, because anyhow another month, 1 month, the baby will be born.
True, true.
But I still can't reveal, because the moment I say the testis is not there, that means I'm actually telling that it's a boy.
Yeah, right.
And in India, we have a strong legislation that you should not reveal the sex of the baby when you're doing this scanning.
True.
It's a punishable offense.
Yeah.
Same thing with hypospadias. A good sonologist would be able to make out in the majority of cases that this is an abnormal penis. But the moment you say the penis is abnormal, that means it's a boy.
Right, right.
So
Also, you cannot terminate pregnancy at a later stage.
You cannot.
Yeah.
You cannot.
The kid has to
So
be
that's
born.
the reason why, unfortunately, or whatever, we are not able to diagnose these things before birth. And as you rightly said, there may not be much of a use of picking up.
Yeah, right.
Of picking up.
Yeah.
So this is what is these. I don't know about congenital heart defects. In fact, spina bifida has come down.
Tell us about spina
because of the
bifida.
folic acid intervention.
Yeah.
You know, but these male genital defects are increasing. This is what we need to keep in mind, and this is what I think a lot of research is already going into it, and if we can find a cause, we need to nip it in the bud. You know, because it ultimately is affecting the human race.
True.
Which is everybody's concern.
Yeah.
So now we come to spina bifida. Spina bifida basically means that the spinal cord, when it is formed normally, when the spinal cord is formed, the spinal cord is encased in a bony structure, the vertebral column,
Yeah.
the vertebra. So what happens is there is a breach in the formation. So, you know, there's a breach in the formation and there is a maldevelopment of the spine. So when this happens, again there are two types. Some of them are visible outside. For example, the baby is born with a water-filled kind of a mass on the spine. It's called meningomyelocele or meningocele. You know, the spinal, everything has opened up. The spinal cord has come out of the bony covering and come out of the skin and gets attached to the skin, and the spinal fluid has come out and formed a bubble kind of thing there. That is externally visible. The second is not visible externally. The skin looks intact. Inside there is a problem. This is called spina bifida occulta. Occult means not seen outside. So both the types are there, and both the types are clearly associated with a deficiency of folic acid in the mother. Now, unfortunately, many people think that after your pregnancy is confirmed, you can take folic acid. But by the time it is late, the spinal cord is already formed. This is a very important point everybody should understand. There is no point in taking folic acid after confirmation of the pregnancy. Because by the time, by the 25th to 30th day after the fertilization has happened, the spinal cord is already formed. In its primitive form, but it is already formed.
Yeah.
So by that time, the spinal bifida malformation has already occurred. So there is no point in taking the folic acid after the pregnancy is confirmed.
So when do you know, what stage do you you're able to find this anomaly when you're doing a screening?
Very easily we can find out. There are many blood tests and other screenings also, but a good sonologist ultrasound will be able to pick up. Unfortunately, we will not be mostly picking up those occulta unless they are very, very, very obvious. But those ones where this projects out and forms a bubble, meningomyelocele, what I said, they are very easily picked up, and they can be picked up in the TIFA. TIFA is about 80 to 20 weeks anomaly scan. They can very easily be picked up in that, in the majority of cases. So one point I want to emphasize is, every woman, whoever is planning a pregnancy, should start folic acid even before conceives. Once you conceive and you know that you have conceived, the window is over. The window is over. So it doesn't form after 3 months or 4 months. It's over in the first 4 weeks. So fertilization has occurred, the sperm has fertilized the ovum. In 4 weeks, it's done. So by the time, nobody will know that they are pregnant actually, because you haven't yet missed a period,
True.
isn't it?
Yeah.
So that is why it's always better. I don't know, but in some countries I think there is this one that folic acid should be given to all women of childbearing age. From menarche to menopause.
Yeah.
Of course, excess folic acid has its own toxic effects, but it's very difficult to consume so much folic acid that it causes toxic effects. But it is better. So at least we need to educate the women who are planning a pregnancy that it's better to take folic acid before you actually plan the pregnancy. That will save a lot of babies being born with these ghastly problems, because what happens is once the spinal cord is abnormal, then then usually it affects the, and most common, it can form in the neck also, it can form in the thoracic chest region also, but the commonest is the lower back, the sacral region, what we call the lower back, lumbosacral region. So, and when it occurs there, the nerves are affected. The nerves that supply the sensation and the muscle power to the lower limbs and control of bladder and intestinal function, control of bladder and bowel. These nerves are affected. Usually the first nerves to be affected are the bladder and bowel nerves. Then the limbs are affected. So once this is affected, in majority of cases, the damage is already occurred by the time the baby is born. This is a problem. So it's not, in majority, it is not a preventable damage.
Yeah.
In majority. So, and then the baby and the parents have to go through a lot of suffering.
So, but it's treatable, right?
It is treatable. See, we can do everything. The problem is the damaged nerves are permanently damaged. So we have actually children who are on a wheelchair throughout their life, and they do not have bladder and bowel control. They do not have bladder and bowel control. So you have to, there are many treatments. Of course, we do a lot of these treatments here because we are actually, Ankura Hospital, we have actually formed the spina bifida, the chapter, Telangana state chapter of spina bifida association. There is a spina bifida association. So this spina bifida foundation rather. So we are the main people in the Telangana chapter. So we are a referral center. We get patients, and we get patients affected in all ways, in multiple ways. So we deal with a lot of these children who have these bladder and bowel abnormalities, the loss of control of bladder and bowel. They are all treatable again, as you said, but
it's suffering.
It's suffering.
Yeah.
It is suffering. So a simple folic acid
Could have saved.
could have saved, if not 100%, at least 80% of these babies, which is a very big number. Which is a very big number. So especially those, the worst affected are those where that bubble projects outside. Where it is inside, they are less affected.
Yeah.
So, and this folic acid actually prevents the worst ones.
Okay.
So that is why folic acid is extremely important. This is very important.
So thank you so much, doctor.
It's a pleasure.
Yeah.